Do you feel that something is wrong in your pelvic floor after your vaginal birth? Maybe you feel a heaviness, or you feel that the vaginal opening is too open, that the vagina takes in a lot of air and that this comes out as vaginal farts. Maybe you feel that your sex life is disturbed by this, that you don't have contact with the penis if you have intercourse with a penis. Maybe you feel that your orgasms are not the same, or that you have pain in the vaginal orifice during intercourse. You might also have problems to evacuate your stool. Maybe you feel that the stool gets stuck in a pouch and that you have to push with your fingers or your thumb in the vaginal wall to empty or to evacuate the stool. Then it can be that you have something that is called an improperly healed second-degree perineal tear. And maybe you can get very much help from a surgery that we called perineal. And this is the topic that we will discuss today. And I work as a urogynecological surgeon, and I think this is the biggest group of patients I see in my clinic nowadays. I see these women, when they come to my clinic, referred to me from other colleagues. I perform this kind of surgery and I follow them up afterwards. So I have a lot of knowledge about this issue, and I have also conducted a lot of research on this topic. So this is very close to my heart. And in this video, you will learn what causes this kind of problems. You will learn how we can treat this group of women. And I will also take you through a study that we did on this group of women. And if you stay tuned to the end of this video, I will let you know what kind of surprise we have for you in the upcoming video, which I think is quite sensational. So let's get started to learn all about improperly healed second-degree perineal tears and the treatment perineal. So first we will speak about the background to this problem. And I want to thank Unheard, which is a Danish company that makes amazing illustrations. And I want to thank them that they gave me the opportunity to use their illustrations in this video. And here we see a woman giving vaginal birth to an infant. You see the head of the baby here with a lot of hair coming out of the vaginal opening. And when you see this picture, you understand that the muscles and the tissues around the vaginal opening stretches a lot. And when we look at which muscles are affected when the baby is coming out of the vaginal opening, we see these two muscles. And if you haven't seen my video about pelvic floor anatomy, I really recommend that you first start to look at this video so that you have knowledge about the muscles and the function of these muscles before you view this video. But in summary, here, right underneath the labia majora, we have a very important muscle called the bulbocavernosus muscle, which is like the lips of the vaginal opening, keeping the vaginal orifice closed. And this muscle starts up here around the clitoris, and it goes behind the labia majora and inserts in the upper part of this area, which we call the perineum or the perineal body. And if this muscle is torn and not stitched together after a vaginal birth, the woman has problem with feeling very open in the vaginal orifice. And then we have this muscle called the transverse perineal muscle that attaches to the skeletal bone laterally here and inserts in the middle of the perineal body. And this muscle attaches the whole perineal muscle structures to the skeletal bone. It stabilizes the anal canal, and it's a very important muscle for the perineal function. And you see when the head is coming out, up here we have bone. So all the force cannot go upwards. So the force have to go down. Here we have tissues that can stretch, and when they cannot longer stretch, they will rupture. So it's super common that a woman who gives birth, especially to her first baby, will have a rupture of this area. And this area we grade into 4 different grades of rupture. We have grade 1, which affects only the skin or mucosa here. But if the bulbocavernosus is involved in this rupture, we call it a 2nd-degree perineal tear. So it can be a small tear, 2nd-degree tear, where only the bulbocavernosus is affected, or it can be a bigger perineal tear, 2nd degree, that goes all the way through also the transverse perineal muscle. And if the rupture affects this structure, which is the anal sphincter muscle, we call it a 3rd-degree perineal tear. And if the rupture goes all the way down to the anus and to the rectal mucosa, we call it a 4th-degree perineal tear. And those tears are fortunately very uncommon. But about 70 to 80% of women who give birth to their first baby will have a rupture of these 2nd-degree muscles. So it's a very, very common birth injury. And when we look at this picture, we see the same muscles but from the side. So here the baby is coming out. Here superficially we have the bulbocavernosus muscle, and here we would have the transverse perineal muscle. We don't see this muscle in this picture. And here more deeply we have the levator ani muscle. And you see that these muscles stretch out more than 350% of their length. All right, and this picture illustrates a woman with a 2nd-degree perineal tear. So we see the bulbocavernosus muscle and the transverse perineal muscle are detached. And one more important thing that we have to say in this matter is that we have the rectovaginal fascia that goes in the back wall between the posterior vaginal wall and the rectum, holding the rectum in place. And this rectovaginal fascia attaches to the back side of the transverse perineal muscle. So if you have this kind of rupture in the perineum, you often also have an injury on this distal part of the rectovaginal fascia. So it's very important that the doctor or the midwife suture these muscles together again after the tear. And most women don't get any chronic problems from this tear. But if you don't suture this properly, or maybe the women will be affected by an infection in this area postpartum, which may cause adhesions of this rupture, it means that the stitches will lose and the rupture will open again. These women can come later, for example, to my clinic with this kind of anatomy. And when we look at this woman, we see here is the labia majora on the outside, and here we have the labia minora. Here is the urethral opening, here is the vaginal opening, and here is the rectum. And when we look at this picture, we see that we can see the vaginal mucosa. The vaginal opening is very open, and we see that there is a diastasis between the labia minora, about maybe 1.5 centimeters in this patient. And here, when you only look at this picture, you directly suspect that the bulbocavernosus muscle is out here and is not merged in the midline. We also we do here a rectal palpation. We can put probably our index finger here and feel this injury in the rectovaginal fascia and this pouch. So when you examine these women, you palpate these muscles, and I have demonstrated this in another video on a real patient, so you can go see this video how you do the clinical examination. And these women often complain of, I don't feel anything during intercourse, or I have pain during intercourse, because this open vagina makes the vaginal mucosa very irritated, and sometimes they have scar tissue in the posterior fourchette that makes them feel pain during intercourse. They often say it's difficult to empty my bowel. I have to help with my fingers to evacuate stool. I have a lot of air coming into my vagina, and I have vaginal farts, which are very disturbing. I feel open. Tampons are falling out. Maybe a lot of water enters the vagina when they swim and then drips out gradually when they come up from the pool. I feel a heaviness in my perineum. I can't find my pelvic floor muscles. So these are very common symptoms that this group of patients present with. And in 2015, me and my colleagues, we were sitting in our outpatient clinic thinking, how can we help this group of women? What evidence do we have? We had many women presenting with this kind of problems, but we didn't really have any evidence-based practice to guide us. Many women are firstly referred to a urotherapist or physiotherapist to perform pelvic floor exercises, because this is a common first-line treatment for many pelvic floor disorders. But we didn't know if this kind of conservative treatment helps this group of women. We don't know if this is wasting people's time. We also have a surgery called perineal, which we perform, but there are no studies evaluating the results of this surgical procedure. And in many countries, and by many of my colleagues, there were sayings that don't do this surgery because you will cause a lot of dyspareunia, which means pain during intercourse for these patients. So they will be very unhappy with the result. So we decided that we have to conduct a study to get more information. So we enrolled a total of 70 women with improperly healed second-degree perineal tears, and we randomly assigned them half into conservative treatment. And they were offered physiotherapeutic consulting, and they got biofeedback, and they get pelvic floor exercises, and were monitored. And then half of the group were scheduled for surgical repair, which we call perineal. And then we followed up this group after 6 months. And when we look at the results of this study, which was published in 2020, we see that here we have the group of women who did the surgical repair, and here we have the women with conservative treatment. And the green box here is the amount of women who got cured at 6 months. And we see that 80% were cured and happy in the surgical group, and only 9% in the conservative management group. So we concluded that surgery is very effective and helps many of these women, and that the conservative treatment as a first-line treatment is not very effective. So which symptoms are cured by surgery? We see that the majority of the women have a sensation of an open vagina. 80% have this daily. And after surgery, this was reduced to 9%. And we also see that half of this group of women had vaginal flatulence daily, 47%, and almost all were cured from this. We also see 46% had digital assistance during defecation, and this means that you have to push with your finger in the vagina or in the perineum to evacuate stool. And this was reduced from 46% to 9% after surgery. And then very interestingly, we found that also urinary incontinence symptoms were reduced after surgery. And this is not so surprising, since we know that the bulbocavernosus muscle will support the urethra. So if you cannot squeeze around the urethra with your muscles because they don't have anywhere to attach, you will have difficulties to hold your urine. And we see that 40% of these women in our study had urge urinary incontinence before surgery, and only 16% at the follow-up. We can see that half of the women had stress urinary incontinence, which means that you have small amount of urinary leakage when you, for example, cough or you laugh or you do some kind of physical activity. And only 1/3 had this problem at the follow-up. So now our routine in this group of women who have an improperly healed perineal tear, but also incontinence symptoms, we start by doing the perineal, so we reconstruct the muscles, and then they can do physiotherapy after, when these muscles can start to work again. And if they still have urinary incontinence issues, when we follow them up, then we can do an incontinence procedure as a step 2 procedure. And then we have these big questions about dyspareunia, which means that you have pain during intercourse. And we see that 65% of the women with improperly healed perineal tears had dyspareunia at baseline before they received their treatment. And after surgery, this was almost reduced to half. So only 29% had dyspareunia at 6 months follow-up. So many women get cured from their dyspareunia thanks to this procedure. And we know that there are some women that get dyspareunia after surgery. We call this de novo dyspareunia. This means that the woman doesn't have pain during intercourse before, and after the surgery she will have pain during intercourse. But in this study we have 0 of these patients. And we know that you can perform a perineal in many ways. There are many different techniques. And we see that if you have a very aggressive technique and you do a lot of dissection and you merge these muscles too strongly, and maybe you reduce a lot of skin, then the vaginal introitus will be too small, and the skin will not be elastic when you have intercourse, and your vaginal opening will be too narrow. So you have to be very careful with that when you do this surgery. And if you want to know more details about this study, you can go to see this paper. It's published in Obstetrics and Gynecology in 2020. And in Sweden, we have a national quality register for gynecological surgery, and 95% of all the operating clinics in our country participate in this register. So we collect a lot of information about gynecological procedures in Sweden. And we look at the statistics in our country between 2013 and 2024. We see that every year, you see here is 2013, we see we did 2,500 procedures every year, and something happened. Here, 2020, our study was published and people in Sweden got this knowledge, and boom, the amount of women who now get help with reconstruction of their improperly healed perineal bodies are now almost doubled. So 2024 we did 5,438 perineal raphies. So this is the best thing with science, that you can prove something and you can help women with your research. And when we look in Sweden at the age distribution of the women who are operated on with a perineal raphy, we see here that it's common from 35 years up to 80 years of age. And now comes the question for many gynecologists: how are the results? Is it different if we do the perineal raphy directly after this birth injury, or can we have the same results even if we do it in postmenopausal women? And when we look at the results in our gynecological register, where all the women gets a follow-up questionnaire 1 year after the surgery, we see that all in all we have 3 of 4 women who are satisfied with the result of this procedure at 1 year postoperatively. They feel that they are cured. So you see here, it hasn't moved since 2013. It was 74%, and 2023, 74%. And when we look at the different age groups, I have divided here. Here in the lower pillar, we have women under the age of 55, so premenopausal. And we have women after 55, so postmenopausal. We see here 71% are happy 1 year postoperatively in the younger age group, and 74% in the older age group. And this difference, I don't think it's clinically significant. So all the women who get this procedure can be helped. And why are the younger women maybe less satisfied? My personal speculation is that they have higher requirements on their pelvic floor when you are younger. Maybe you do more sport activities, you are more sexually active, you have higher demands on your pelvic floor. So now we know that perineal is something that helps women. We should be trained in this, and we should continue to do research to find the optimal technique.